our next speaker, we are really delighted to have John Mattison with us. And I'm really happy to give him the floor. He's better really in introducing himself than I am, but he is an authority, of course, in the other side of the ocean, in the US. In the US, everything is bigger and better, but in this case, it is. So I'm really happy that he is here. We have a slight delay. I'm sorry for that, but I really urge you to listen to his story. It will be 45 minutes, but once you hear him talking, time flies. So, John, it's my honor to invite you here, and it's my pleasure to listen to you. Thank you so much.
Thank you for that very kind introduction. Since this is a conference about technology, I want to tell you what just happened to me is they handed me this technology here to change slides, and I was looking for the pointer, and then I realized the only way I could use a pointer was to do something like that with the 4 slides. So the pointer's not necessary today. What you've heard about today so far is a lot of what is happening and what is cool in the mobile health tech space. And I'm going to talk a little bit about why mobile healthcare and virtual healthcare is so important, and how we need to think about framing what we do. We reviewed our own progress in this 2 years ago and found that we had 571 simultaneous digital health projects going on at Kaiser Permanente. That was madness. So we decided that we were going to try and stop as many of those as we could and focus on a few things. So what we're focusing on now is doing diabetes management at scale, doing hypertension management at scale, and the next one that I'd like to do, we haven't confirmed the next target to do at scale with 20,000 physicians and 10 million members, is mindfulness, because it's so much at the core. So an earlier reference was made to how at Eindhoven you have everything here that we have in Silicon Valley. I just want to point out that the reason I still live in San Diego is because the waves are far better in San Diego. So we still have something to distinguish ourselves. I like to use an image of a wave as what's happening in digital healthcare, because we have 2 choices. We have all these waves of new technology, exponential changes in technology, exponential growth in the amount of data that we have access to and the type of data. We have 2 choices. We can be buried by it, as in a tsunami, or we can learn how to surf. So I highly recommend learning how to surf. Those of you that are coming to San Diego for exponential medicine in the next couple days, I have an extra surfboard. I'll be happy to loan it to you. The title that I chose for this talk today is How Can the Sci-Fi Generation, and I like to think of all of us as part of the sci-fi generation, if we can imagine it, it will happen in our lifetime. There's never been a time in history when your imagination is your only limitation. And how do we use modern technology to restore ancient wisdoms? There's lots of cool whiz-bang, bright and shiny objects that we can use, but how do we choose which ones are going to make a difference? And we all know there's been a lot of published studies in the past couple of months, casting some doubt on whether or not all this mobile health technology is actually going to make a big difference or not. There was one published last week showing that layering a digital mobile app on top of established physical social networks for weight loss gave no incremental benefit. So how do we understand what it is that really makes a difference, that really can move the needle on health of a population? And I like to think of this thing here, not as a cell phone, but as a puck, a personal, universal communicator. What it does as a cell phone is just one of its many functions of communicating with people and things near and far using multiple different communication modalities. And I like to think of it as stationary, not mobile, because it never leaves me. It's stationary with me. And I think that's not just a semantic distinction. It really does influence the opportunity of how we can take care of ourselves. So I'm going to try and go through a couple of things. First, I was asked to talk a little bit about Kaiser Permanente. So how many of you have heard about Kaiser Permanente? Just a quick show of hands. So most people. And how many have emailed your own doctor? Sent an email to your own doctor? Maybe 5%. How many have reviewed your own health record online? Another 5%. How many of you have had a video visit with a doctor? Anybody? Nobody. Oh, one. Okay. How many? Two. Thank you. How many are wearing a sensor today? Okay. How many have ever worn a sensor but are not wearing one today? Okay. So there's a little bit of evidence right there. So 3 times as many people have worn a sensor as are wearing one today. So I like to think of most of the sensor technology today are basically functioning as digital nannies, and that we need to think much more about how do we convert that information into mindfulness and resilience rather than using a digital nanny. So how many have had anybody had their genome sequenced? Okay, couple. How many have heard of the ecosystem economy? Okay. And how many have heard of blockchain? Oh, wow. Okay. All right. So many of you probably went to Our Future Health at Radboud and with my friend Lucienne Engelin, and there was a great presentation on blockchain there. So there's going to be very disruptive in healthcare. It's not a flash in the pan. All right. So I like to think of the Maslow hierarchy of strategies. So a lot of strategic planning for digital healthcare and healthcare in the future starts off with the technology at the top of the hierarchy, and I think that's a huge mistake. We really need to think about what is our goal, and I believe in putting the person first and putting person-centric goals in health and resilience and wellness ahead of any other priority. Right below that is the values that we use to achieve that goal. Right below that are the organizational structures to support the values. And then finally, the technology has to support that. So when we're thinking about our strategies for digital health, let's make sure the technology is not driving the strategy, but it's actually supporting a strategy. So I can talk a little bit about Kaiser Permanente itself, and a lot of it is the relationship between the care delivery network itself and all the physicians and nurses and pharmacists with the health plan and the hospitals. So we have a completely integrated system. We're fairly unique even in the United States in having that kind of a high level of integration. There's a creative tension between the health plan and the physician groups. There are trusted relationships and governance models that really help us make decisions together, focused on common values and common objectives. And transparency is really key to how we achieve our goals with our values together. I just want to say a little bit about Sidney Garfield, the physician who's the founder of Kaiser Permanente. And I like to think of him as the Steve Jobs of healthcare. He really did map out the entire vision, the organizational structure, the strategy. And oh, by the way, 46 years ago, he published this. This is his vision, published in 1970 in Scientific American. He'd been talking about it for a decade before he published it. So this essentially was created before the advent of the personal computer, the internet, or the cell phone. But his view was very much that, as you see at the top, health testing and healthcare and preventive maintenance were very central to our mission, in addition to taking care of people who got sick. Today, this looks kind of dated, but in fact, in 1960, when he started talking about this stuff, it was terribly revolutionary. When we went to automate all of our systems across our entire enterprise for our 180,000 employees, treating 10 million members, I used one slide as the business case, and that is that we needed to reduce the cycle time of learning. So that this is the classic quality improvement cycle where we observe what happens in practice and in process. We do the analytics and the modeling and the simulation. We do lots of modeling of if we lowered the target LDL cholesterol, how many less parking spots would we need in the clinics? And then the decision support, and then back through the cycle again. So the cycle represents both evidence-based practice and practice-based evidence. And that complete loop of doing what you do because of evidence and then taking the evidence of what you've done is increasingly important for improvement. What used to take 17 years in practice to go from a paper report of a result into practice now takes us minutes and days. So we literally take new knowledge and implement it in a very short period of time. So the continuous improvement includes clinical outcomes, patient satisfaction, cost outcomes, functional outcomes, getting people back to work, evidence-based practice and practice-based evidence. And I want to mention a little bit about practice-based evidence. So one of the projects I'm working on right now, and I've spoken to several of the participants here in the Netherlands on the Global Alliance for Genomics and Health, is how do we reduce the friction of taking care of someone like a 45-year-old woman with breast cancer who has a very specific pattern of genetic mutations that identify what she's likely to respond to or not, and be able to search the entire globe for women like her, and then get consent to see how each one of them, let's say we find 150 of them, see how they were treated, find the best therapy, and then implement it based upon a global search of practice-based evidence. So we're working on that right now. We hope to launch that within a month. The Netherlands, Australia, UC San Francisco, and UC Santa Cruz are the 4 sites, and I'm trying to get my company engaged with that as well. Finally, physician satisfaction. It used to be the triple aim, and what's happened is there's been a lot of doctor burnout, and so they've added physician satisfaction. The reason doctors are burned out has been ascribed to many different things, but in point of fact, the example of, you know, I'm too busy dragging the cartoon earlier to put wheels on the cart. The other metaphor is I'm too busy sawing to stop and sharpen my saw. And this is the way every primary care doc feels today. And this is why as much as 80% of primary care physicians around the world are really burned out. And when you say, oh, so in addition to what you're doing, we need you to get involved in digital tech, we need to get you involved in mindfulness, we need to get you involved in the social determinants of health, they're feeling maxed out, and it's hard to get their attention. So when we think about why it is what we do and what it is that we need to do and how we do that, we need to realize that health in and of itself is a subset of happiness. And what leads to happiness, and why are some people happy and as a result healthier and more resilient? And I think it's important that we look at the why, the real deep why of what's going on with that. So health is really a subset or a byproduct of happiness with mind, body, and spirit. But there are 3 principles that I like to think of. The first is having dignity and purpose by having a useful skill that is appreciated by our community. We make a difference, and it's appreciated by our community, whether it's our family, our household, our professional job, or whatever. Gratitude and forgiveness, and an opportunity to learn and innovate. And so those seem like mom and apple pie and really straightforward and lofty goals. But in fact, if we neglect those and all we do is treat the blood sugar or the blood pressure, we're really missing the point, and we're not getting at the true source of happiness and hence health. So I like to think that happiness is a choice, gratitude is a discipline, and health, resilience, and joy are the outcomes. So Vint Cerf is actually the inventor of the internet. He invented TCP/IP. He's a senior fellow at Google, an evangelist for the internet. And I've been recruited to work on a couple of his initiatives where we're bringing the internet to the darkest corners of the world so that everybody can engage in the global economy. And we're also looking at how the disruption of jobs with artificial intelligence and robotics is taking away the dignity of so many people by taking away their sense of purpose. And there's a whole lot of things happening around the world with populist politics and Brexit and things like that that are very much related to a sense of loss of dignity related to jobs. So as technologists, as we see AI and robotics taking people out of their jobs, we need to realize that we are on the forefront of reducing dignity in large populations, and we need to be very careful how we do that. So these initiatives are very much targeted at changing that. I started a work group within it called Childhood Reimagined to take a look at how we need to set healthy habits and resilient habits in early parenting and early childhood. There's an economist at the University of Chicago that has actually shown that you get a 7-to-1 return on investment by investing in healthy habits in children throughout the life of that individual. So there's actually good economic evidence that we may not be focusing enough on parenting and early childhood experiences. So how many people, just show of hands, how many people have heard of blue zones? Okay, so guy by the name of Dan Buettner studied this a long time ago, and he looked for places around the world where people live longer and healthier lives than anywhere else, in Japan, Italy, Costa Rica, Greece, and in California. And he tried to establish what are the common factors that lead to long, healthy lives. And so there were 3 that everybody knows about: regular, healthy exercise, fresh, local diet, regular sleep. And we now know that when we're sleeping, we accelerate the rate of clearance of the beta amyloid in our brains that leads otherwise to Alzheimer's disease. And 4th, and perhaps most importantly, is social health. And this is really often neglected. The influence of our social network on our health is profound. If you haven't read the book Connected by Christakis and Fowler, I highly recommend it, because they do the science of looking at how your social network very directly and very profoundly impacts your health. And there's a study published by Carnegie Mellon University last year where they had 400 people that they exposed to a virus. And they saw who got sick and how sick they got. And then they looked at their Facebook feed to see how much social stress they were under and how much of a social support system they had. And what they found was fascinating, that there was a lower incidence of getting infected, there was a lower incidence of having severe symptoms in those people that had a stronger social support structure. And one of the metrics was how many hugs have you had in the last 2 weeks. It didn't matter so much whether or not you had a lot of social stress in the preceding 2 weeks. It was much more important how much of a social support network you had. So as we start thinking about digital healthcare and how are we going to really move the needle on the health of a community and the health of a population, it's these sorts of things that have been shown through profound epidemiologic evidence to be really important. So there are a lot of old solutions that people have recommended for decades that have been pretty much neglected that we need to resurrect as we begin to think about how we bring technology to bear on these problems. So Dean Ornish is a champion of healthy living and loving. He's the first to really demonstrate at scale that you can reverse coronary artery disease by lifestyle modification. He actually has large cohorts where the coronary disease has actually been lessened by lifestyle modification. There's the notion of positive deviance, where you look for institutions, for doctors, for individual patients who are actually doing better than their peers, and then you find out what is it they're doing, not just one cute little thing, but in the context of the workflow, the context of the organizational structure, and how they organize themselves around improving health. And my friend Cole Zanetti actually is taking this to the next level with individual patients who are beating the odds, and he's studying them and finding out what are they doing and then using them as mentors for people in a group, rather than just throwing people together in a social network and having them talk, actually identifying the positive deviance and having them help. And then, of course, Dartmouth has done a lot of health maps looking at the social determinants of health. And one of the things that it's easy to falsely assume is that if you look at an underprivileged or socioeconomically deprived area, that there's going to be a higher incidence of all bad stuff, and it's really not true. So this is a map of the San Francisco Bay Area, and this is the prevalence of obesity, and you might think, well, that's going to be the same for asthma, which it's not, or the same for depression, which it's not. So if you look at these maps and the overlays, there's very different arrays in different communities. So we really need to spend some time and understand what is it about these communities that lead to such a different array of consequences of the social determinants of health. And so I also like to think that population health care is obsolete. So we've been doing it for many decades, where you look at everybody that has diabetes or everybody that has high blood pressure or everybody that has coronary disease, and then you risk stratify and you focus your effort on those that are worse. Well, the problem is that most people have multiple comorbidities associated with, for example, diabetes. And in addition to that, we shouldn't just be focusing on disease management, but also focus on the wellness and resilience, so that once we get control of their current problem, that we're not neglecting the opportunity to do more preventive health care and wellness. There's a book written by someone called Dambisa Moyo, and it's called Dead Aid. And we've all heard of Live Aid, the fundraiser for Africa. She looked at what's going on in Africa in terms of all of the foundations that have come in and tried to save the world with their very specific initiatives. And in point of fact, what she documented is many billions of dollars have been spent and wasted, and some of them have even been counterproductive. So as we start thinking about how we introduce digital healthcare into community health and address these social determinants, we really need to be much more systematic in applying the same discipline of evidence-based medicine to evidence-based community health and personalizing care. So I've just listed a number of things that for which there are methods to apply an evidence-based approach which are largely neglected. So how do you have a health assessment tool? How do you validate that with the community? How do you benchmark across communities? How do you do an assessment of the local capacity? What are their strengths and weaknesses? How do you assess the local appetite and their values and priorities for taking on individual problems? How do you do the analytics to sequence and synergize the tools to address those needs? And then validate progress against metrics, and ultimately with a goal of self-sufficiency and resilience. And then how do we systematically apply the hot spotting whenever possible? So this is Lucy. She's a 2-year-old who lives across the street from me. Her parents are dear friends. And Lucy, earlier this year, had a fever of 105 degrees and a very significant rash on her back. And so her parents, like any good parents, were worried about her, took her into the emergency room, and sat for 2 hours while all the other children and people in the emergency room coughed all over her. They got fed up that they were exposing their daughter to more disease than she came in with, and they took her home. The next day she was worse, and they took her back in, and exactly the same thing happened. So they spent 4 hours in the emergency room, were never seen, and exposed poor Lucy to a lot of other potential infections. So I'm going to come back to how that might be different in the world of digital healthcare a little bit later. Was it the what? No, it was not. It actually was not my hospital that she waited twice for 2 hours. I would have made sure that that didn't happen if it had. So I like to think, as a recovering evolutionary biologist, I like to think about natural metaphors that help explain what's going on in our world today in digital health. So there's 3 metaphors I like to think of. The first is the inverted Big Bang. So 14.2 billion years ago, all matter and space were concentrated in a single point in space and time. Big Bang, and there's been an accelerating rate of dispersion of all energy and matter ever since. What's happening with digital healthcare is that we're seeing an exponential growth in the types and the amount of data that we have that are converging at an accelerating rate into a single point in space and time. So this is the tsunami that we really need to help manage, and I think wearable sensors are potentially very much part of the tsunami, that we need to understand how to create signal out of noise and how to use that signal to motivate healthy behaviors rather than to just operate as a digital nanny. The second metaphor, my daughter came to me in high school biology and said, "Dad, I really don't get meiosis. Can you help me out?" So like any good father, I went to YouTube. And there's some great videos about what happens in meiosis. And what happens in meiosis is there's 3 rapid successive generations of massive mashup of ideas. So the first is you take the maternal and the paternal chromatid, they hook through the kinetochores, they swap genes, consider them ideas like crazy. Then moments later, they randomly assort, so half of the sperm and half of the egg is from the mom and half is from the dad, randomly. And then days to weeks later, sex happens, and you have a third mashup. So there is an extraordinary, deliberate, this is the most innovative engine on the planet. Nothing that we've been able to imagine or create even comes close to the innovation of meiosis in terms of mashing up tens of thousands, if not hundreds of thousands of ideas 3 times in a very short period of time. So this is really to generate the diversity that gives us the resilience. So we need to be aware of the fact that this diversity is deliberate, and that our strategies around digital healthcare have to recognize that this diversity is deliberate and address some of that diversity, and I'm going to come back to that in a minute. The last metaphor, and if you ask a lot of folks how far they've gotten with big data analytics, and the answer is not so far. A lot of the problem is that you take data scientists who have great statistical skills and great machine learning skills, and you give them access to massive amounts of data, and it's very hard for them to come up with something meaningful. And so I like to think of the tropical rainforest as somewhere where there's not a lot of nutrients, but there's a maximum of diversity and a maximum efficiency in capturing solar energy and converting it into carbon-based life. And so I like to think of a metatropical rainforest, and it's actually very relevant to what's happening in big data analytics today, is that all too often we have data scientists sitting next to their PC doing analytics, not having a clue about the nature of the data they're operating on. So we need to have subject matter experts from across the data sets that are being operated on to really begin to interpret and make sense of big data. So the hype about big data still vastly exceeds the output, but I'm extremely optimistic that when we learn the lesson of bringing subject matter experts across the subject matter space to bear, along with the data science, we will have much more effective big data analytics. And one of the most compelling new sources of data is the microbiome. So I don't know how familiar, I'm sure some of you are very familiar, others not so much. We now know that there's 100 times as many genes in the bacteria in our gut as there are in the human genome. We also know that a child that's had a C-section, because they get the microbiome from the skin of the mother rather than from the vagina or the vaginome, they actually you can determine at 5 years of age whether they had a C-section or a vaginal delivery because it persists. They also have a much higher incidence of asthma. Well, there's now over 100 diseases that have a specific signature of the type of bacteria in the gut that's associated with that disease. And the correlation causation issue is still not resolved in every case, but there's circumstantial evidence that's profound that these changes in our gut bacteria are having a big impact. And in fact, one of the most compelling examples is that children who receive excessive antibiotics before the age of 5 and they really disrupt, cause a dysbiosis in the gut. By the age of 15, you do an MRI of their brains, and their gray matter is very abnormal and looks just like the gray matter on an MRI scan of someone who has chronic anxiety or depression. And there's circumstantial evidence along that whole pathway that those antibiotics cause the dysbiosis, cause the change in the immune system, cause the change in the way the brain was wired, and leads to chronic health issues. So I mentioned the ecosystem economy earlier. I'm not going to spend a lot of time on this slide except to say that all of these are platforms. Ecosystem stands for multi-platform ecosystem, which is the exponential world that we're living in today. And there are service platforms like the cloud, the smartphone, Alexa. There's data platforms, API, application programming interface platforms, experience platforms, and so forth. All of these are evolving at exponential rates, and they all have an impact and represent opportunities that we can exploit for digital healthcare. So there's 5 principles I like to think of about how to leverage this. And a lot of the solutions in digital healthcare today just pull a very isolated thread out of one of these platforms and focus on it, when in fact we really need to create a behavioral symphony of wellness that has a much more comprehensive solution for how we're able to manage for health and resilience. So the first is each one of these has exponential growth. The second is there's synergy and convergence. When you use cross-platform convergence, there's data liquidity that you can begin to look at things that were previously unimaginable because you couldn't put the data into the same environment for doing data analytics. There's the person centricity of that information. And then the final one is that open source communities really accelerate the rate of change. 4 models of innovation: the classic disruption, Uber, Airbnb, Google. Incremental optimization, which is what most of us do in healthcare systems. Spread, local successes with positive deviance and hotspotting. And most importantly, cultural transformation. Takes the most time, but is by far the most critical to align all of the initiatives around a common set of objectives and values. I'm going to skip that. And I'm going to talk a little bit about wearable sensors. And basically, I like to think of 4 different types of sensor information, 4 different contexts. The first is the athlete and the warrior, where we're really fine-tuning the warrior or a super athlete. There's acute illness, where we have monitoring in the inpatient environment. There's chronic illness, which is what we're working on with diabetes and hypertension. And then the 4th one, I think most importantly, is restoring wellness and resilience. And I do think the reason that many of us have worn pedometers and don't have one on today is because we get fatigued of the digital nanny pretty quickly. So what I recommend that people do with a pedometer is stop looking at it so frequently, and instead of saying, I need 100 more steps today to meet my goal, when you see an elevator, say, where's the stairway? And systematically become more and more unconsciously mindful of what it is you need to do to sustain your health. It actually works. And then you can use the digital technology not to be a digital nanny, but to initiate the desired behavioral change, to motivate until you reach a target, and then to periodically calibrate. And there's already 2 products on the market, Heart Health, which is just a simple clip on your ear that plugs into your cell phone. It gives you a very simple red, yellow, blue indicator of the stress level that's affecting your entire body through the final common pathway of your heartbeat. And the goal of this company is to get you to, as quickly as possible, know how to keep yourself in that blue zone nonstop so you can stop using their device. They want you to train yourself as quickly as possible so you stop using the device. Likewise, Muse measures brain waves, same thing. There's a startup here in the Netherlands that I had lunch with the founders yesterday called Happy Tech, which does the same thing with measuring, simply putting your thumb over the camera on your phone and doing something very similar to what Heart Health does without any extra devices, just simply from your smartphone, again, to help you manage your stress level with very simple tools. We do know that how we manage our stress, how much resilience we have, and how much mindfulness we apply to managing our stress has probably more to do with our long-term health than just about anything else. And so being wary of that, being cognizant of that, and focusing on mindfulness is why I want to make that our next, after we do the diabetes and hypertension, why I want to make that our next priority to get at scale across our populations. So there are 3 conversations that we need to support using digital healthcare. And I like to, the first is the patient with their professional care team, the second is the patient with their personal care team, and the third is the patient with the person that houses them. So it's my belief that using big data analytics and using visualization tools that we should be able to support all 3 of those conversations in the following way. 45-year-old woman comes in the office, happens 1,000 times a day, with a new onset of diabetes and hypertension. And you say, I've got 3 options for you, and you use visualization tools to show these options. One is, you need to radically change your lifestyle now, and your diabetes and your hypertension will go away. And I mentioned earlier that people have already shown that they can completely reverse those disorders with lifestyle change. The second option is take these 2 drugs, one for your diabetes, one for your hypertension, and come back in 2 months. And the third option is somewhere in between. And what we need to do is to be able to visualize the mashup between everything we know about her and everything we know about diabetes and hypertension and behavioral modification and motivational science, and apply that in a way where it's really easy for people to make a choice. Well, in this case, it's incredibly easy for her to make her choice because she says, guess what? The reason I have diabetes and hypertension all of a sudden is because I'm so stressed out. My daughter's getting married in 2 months. I'll take option number 2, just give me the 2 pills. Once I get my daughter married and get all of my in-laws out of town, I'll be back, and then I want option number 1, I'm gonna change my life. I don't wanna have diabetes, I don't wanna have hypertension. I'm gonna do what you tell me will help me achieve my goal of being drug-free and disease-free, and that's really true. So I like to think of patient-centric, which is quite the buzzword in the US these days, as an oxymoron, because patients are what doctors call people, and people have more than high blood pressure and high blood sugars. They have lives, and the majority of people who have diabetes who are not responding to therapy because we call them non-compliant is because we didn't take the time to understand that they're depressed. And we didn't begin to treat their depression so that they could manage their diabetes. And we didn't take the time to figure out why it is that they're depressed. Is it because their son is using drugs, or their daughter is pregnant, or a teenage pregnancy, or their husband just left them, whatever. Until we restore empathy and understanding of the whole person into the equation, just treating the blood pressure and the diabetes is not going to get us where we need to go. We already know that. What we're doing is not working. The epidemics of lifestyle disorders are rapidly increasing worldwide, and we need to focus much more on the underlying cause. I do want to mention what we're doing with video. So we do a couple thousand to 2,000 video visits a month, and our goal is to create what I call video dial tone. This time next year, I hope to have 10,000 video visits a month, and there are 3 basic types. I want to see my doctor who knows me and can follow up with me, versus I want to see any doctor now, versus I'm being discharged from the hospital and I've got an infusion catheter and I've got a shunt and I can't remember everything you tell me and reading it on the document doesn't work, so I'm going to give you a complete instructional video that's customized for you and that you can look at over and over again. So those are the 3 modes of video. It's critical that we develop an evidence basis like we do for everything else, not only in how we use video and what problems are best, but how we look at personal preferences. Some people will prefer text, some email, some video visits. There will be times when the convergence of those two is just fine. There will be other times where we know that someone needs to come in and be seen as opposed to be seen on a video visit or be managed with text messaging. So we have this sort of concentric circles of the evidence basis for what works and the evidence of what people prefer, and there's a whole new science that will be developing about the intersection of those two circles and how we efficiently and effectively and safely manage care. And just to highlight again, in all of this, we need to start managing social determinants of health early in life. So finally, I want to talk about what I think is the biggest missing factor that we really need to put as a core objective and a core value for what we do. What's happened is the empathy that used to characterize the relationship between us and our physician has been really left aside with the distractions of time pressure and the distractions of technology and the transparency we have into all this data now. So we can't escape the fact that we can see all the care gaps for individuals. So I like to think of a couple ways of addressing this, and I'm working with a couple of vendors and researchers to do this very explicitly. And so the first is what I call a motivational formulary. So we have drug formularies because different people respond to different drugs for the same condition. Well, guess what? There's quite a science in motivational science about how different people respond to different motivational therapies. There's actually a standardized survey that can be administered at essentially no cost that will tell you this person responds really well to humor. This person really wants you to be directive and say, you will do these 3 things. This person over here really wants to see all their options and they just want to pick one. And yet someone else wants to discuss those options at length, either with their physician or with their family or with their social network on that particular issue, which may be different depending upon what the issue is. So that's what I call the motivational formulary, and Frame Health is the vendor. I looked for 10 years before I found a mutual friend called me up and said, John, I found your guy, because I'd been looking for 10 years for someone who was doing this. There's a company called Frame Health. I have no conflicts of interest with any vendors, who actually has developed this motivational formulary. We've been working with them for 5 years, and there's a rapid iteration, and we're learning very quickly how to identify which kind of tools, motivational tools, which work for which kind of person. Our care managers who take care of people with chronic disease who are using this tool in conjunction with conventional tools and other digital health apps are finding far greater response rates of people when we actually understand how to motivate them as opposed to their neighbor or their husband or the next patient with the same problem. And the second term that I invented to think about this space is called motivicons. We all know what emoticons are. Well, a motivicon can be a video. It can be a text-based instructional document. It can be a text itself. It can be an in-app reward. But we need to have a large palette of motivicons that we can draw on in our motivational formulary to help motivate people towards their goals. So we need to make sure that we're, first of all, addressing their needs and their goals through empathic design and true empathic relationship, and shift from the digital nanny towards mindfulness and resilience. And again, I can't emphasize enough, my wife's told me her entire life, she works with children as a speech pathologist, that we have it upside down. We're trying to teach our children. We need to learn more from our children as well. We need to look at what it is that they view as important and begin thinking more along the lines of what they do as what's important in life. So I described what happened to Lucy, our 2-year-old neighbor, last January. 2 trips to the ER, 2 hours each, people coughed all over her, no benefit whatsoever. So by the year 2020, what I'm going to describe now are technologies that all exist today. So I've avoided the whiz-bang, bright and shiny object stuff. I'm going to do that now, so warning, this is the whiz-bang stuff. But it's all here today. So I'm a senior advisor to the Tricorder X Prize, and I work with loads of sensor vendors. And there is an amazing amount of things that are possible today, but how we integrate them into a workflow and really think of this in terms of a solution set for a specific problem is really important. So here she is with a fever, and a rash. We know she's got a virus. We don't have a clue which one it is. We don't want to take her in and have people cough all over her. So what do? There is a tool today. I actually awarded the Sensor Prize, the X Prize in Sensing to a company that produced a product called Gene Radar, which uses polymerase chain reaction. You could just, in 4 years, I believe that this would be fairly commonplace and inexpensive. Take a swab of the mouth, put it in a device, check what DNA and RNA are in there, determine which virus it is, and determine what the antibiotic sensitivity is. This can take, today, minutes. This is already happening for Zika virus, and for Ebola virus, and for chikungunya. So this is technology that exists today. It's not widely distributed. As William Gibson, the famous sci-fi writer, said, the future is already here. It's just not evenly distributed, and I would add, and converged. And so we'll be able to know what virus and what antibiotic sensitivity she has. We'll be able to upload that instantly to her pediatrician, who will have the complete medical record, including her pharmacogenomics, that which determines her risk of side effects and what a loading dose is and what kind of dosage she'll need of the antibiotic that's relevant to this virus. And then we'll call up UPS, who has already announced that they're going big into drone delivery of packages. And so a minute to get the virus and the antibiotic sensitivity, a minute for the doctor to upload it and approve the antibiotic order, and then in 3 minutes a drone arrives and the antibiotic is on the front door. 5 minutes from the time that the test was done to when the appropriate antibiotic was delivered. All that technology exists today. Converging it into a solution set is something that I'm not good at time. I'm guessing 4 to 5 years, hopefully not too much longer. So this is Lucy in 2020. She really appreciated that drone. She loved the drone more than anything. The antibiotics didn't taste that good, but she loved the drone. Okay, so what are the implications for the future of human evolution? And as an evolutionary biologist, I like to think about this a lot. So the first is sort of using all these sensors. The first is what I used to resemble as Homo geekus. That was me 5 years ago. That's why I don't sit unless I absolutely have to sit down, because sitting is the new smoking, and we know that your genome changes radically. You're up and down regulating stuff, and very unhealthy within 40 minutes of sitting down. Sorry, you've all just taken a few days off your life. Not that long. This is thanks to McDonald's and other fast food. We have Homo fast fooder us. And during the design of the flat panel display, something went terribly wrong. And then this is sort of the Homo telemetricus, which is where we have this fine-tuning of athletes and warriors. And then finally, and most importantly, what I think is, in addition to bringing about social health and bringing to bear all these motivational sciences and behavioral sciences and behavioral economics and technologies to bring much more social health into our lives, there's a tremendous amount of evidence for the benefits. And last year there was a study published showing, again, the brain rewires if you do transcendental meditation. It rewires in really healthy ways. There's demonstrable difference in what your brain looks like after a couple years of TM than it does before, and they're all towards the healthy. And Eric Schott at Mount Sinai in New York is studying all the micro details of the proteome and the metabolome and the transcriptome associated with meditation. And the changes are profound. So what I see as the hopeful future is that of Mindful Man, where we spend much more time with mindfulness and resilience. And I think if you look at some of the many failures of digital health tech, it's because we're not looking at end-to-end solutions. We're not looking at creating mindfulness. We're doing too many narrow solutions, and we need to look much more at converging the technology together. So finally, a quote that sits at Health and Human Services in the US, and it says, "It's been said that the moral test of government is how that government treats those who are in the dawn of life, the children, those in the twilight of life, the elderly, and those who are in the shadows of life, the sick, the needy, and the handicapped." And while a lot of people in Silicon Valley like to say that a rising tide raises all boats and technology will help everybody, we know that's not true. And as technologists and healthcare delivery professionals, we need to pay attention to our entire populations. And the very last slide, Maya Angelou, the poet laureate, said, "I've learned that people will forget what you said, people will forget what you did, but people will never forget how you made them feel." And we need to restore much more empathy into what we do every day. Thank you very much.